Good morning or good afternoon. I'm going to speak. This is Dr. Brian Fallon from the Columbia University Medical Center. I'm going to be talking to you today about a 4-lab comparison study that we recently published in Clinical Infectious Disease, the rationale for the IL-1 beta assay, which is a new diagnostic assay, and the PROMISE outcome measures. I have received support for research and training from the M.P.H, New York State, the Lyme Disease Association, Lyme Research Alliance, and the Tick-Borne Disease Alliance, as well as support for diagnostics research from Boulder Diagnostics and Oxford Immunotech. The paper we published is called A Comparison of Lyme Disease Serologic Tests from 4 laboratories in patients with persistent symptoms after antibiotic treatment. We asked 5 questions. 1. Do labs differ in the likelihood of detecting a sample as positive? In other words, are the labs equally sensitive? Are the labs concordant, or do they disagree with one another? Will a positive result at one lab also be positive at the next lab? 3. Is the percentage of false positives comparably low at the different labs? 4. Do the in-house lab criteria, which some Lyme specialty labs have devised to improve sensitivity, do the in-house lab criteria for interpretation of Western blot provide an advantage over the CDC criteria? And 5, how does the IgM Western blot perform using post-treatment Lyme disease syndrome samples? For this study, we collected serum from 37 persistently symptomatic treated patients with well-documented prior Lyme disease. We also have 40 asymptomatic medically healthy controls without a history of Lyme disease diagnosis or treatment. Remember, the 40 medically healthy controls had no symptoms and no memory of having had Lyme disease. Samples from each subject were sent to 4 labs, a university-based Lyme lab, a commercial lab, and 2 Lyme specialists. So is there a difference between labs in the percentage of positives? No. They actually had comparable performance. This surprised me. I had expected that the Lyme specialty labs might be more sensitive, but in fact they weren't. All labs performed comparably. You had 70% or 65% positivity on the ELISA at each of the labs. So this pattern looked identical. It was remarkable. But discordance was found to occur. So the results actually vary depending on the lab, especially with the ELISA. So if you look at the ELISA here, you'll see this blue line. There were 12 discordant pairs between the university and the commercial lab. So the university might say a sample is positive, the commercial lab would say it's negative, or vice versa. The commercial lab might say it's positive, but the university lab would say it was negative. Same thing happened with university versus the specialty lab A. 14 discordant pairs here. So Lab A said one thing, university lab said the other, so even though they each had a sensitivity of 70%, it wasn't the same samples they were detecting as positive. So this is terrible. 1/3 of the time the ELISA would be discordant at these in these situations. So that's a problem because we have the ELISA, if it comes back negative, physicians normally would not order the Western blot. But if it was sent to a different lab on the same patient on that same day, it might come back positive. So this is not a good situation. In addition, sometimes the ELISA is negative, but the Western blot IgG can be positive. Now, the Western blot IgG everybody recognizes using the CDC criteria as a highly specific marker of having been exposed to the agent of Lyme disease. And it's extremely useful in that regard because when it's positive, there's no doubt that this individual has been previously exposed to the agent of Lyme disease. Well, some of the time the ELISA may be completely negative, but the IgG Western blot positive. That doesn't happen a lot, but it happens in between 1 and 3 of the samples out of 37, depending on which lab you sent it to. So that's important because physicians often and healthcare providers often don't realize that if the ELISA is negative, the IgG still might be positive. So clinicians may consider requesting an IgG Western blot if the ELISA is negative, but the clinical picture and the exposure history support the diagnosis of Lyme. The percentage of false positives turned out to be comparable among the 40 medically healthy controls on the tests of the ELISA and the IgG Western blot and the two-tier assay, which is the CDC more specific approach. And the C6 peptide did very well also. So the ELISA, the IgG Western blot, and the C6 peptide performed. The individual actually had been fatigued at the time you did the test, but fatigued for another reason. Let's say didn't get enough sleep, and you did this particular approach, and it came back positive. This person might erroneously be put on antibiotics for presumed Lyme disease, when in fact it had to do with something else. So in summary, the labs had comparable performance in terms of sensitivity. The in-house criteria for Western blot interpretation did not improve the situation, and the IgG Western blot and C6 ELISA had good specificity. However, because of high discordance among the labs, clinicians may consider sending serum to a second lab if Lyme disease is strongly suspected clinically and the lab test has high specificity. So what are the limitations of this particular study? Sample size was not that large. And you always have to ask the question, were some of the medically healthy controls previously infected? Possibly a small number, as these controls lived in the Northeast. Not a large number, but possibly a small number. But these individuals, the main point is that they felt healthy and had no prior diagnosis or treatment for Lyme disease. Antibody-based assays clearly are problematic. We need a sensitive and specific marker of active infection. Indeed, a good test would be positive when the infection is present and negative when the infection has resolved. Now, classically, we were all trained in medical school that two types of immune responses exist. There's the early innate rapid immune response that is nonspecific, just like a shotgun response, and then there's the adaptive immunity, which is a much more fine-tuned, slow response that is highly specific, where you have T cells and B cells, and the B cells produce the antibodies that most current serologic assays, FDA-approved assays, are based upon. It's based on the slower adaptive immune response rather than the early innate response. Now, one question that has emerged recently as a result of exciting new immunologic findings is, can a test be devised using the more rapid shotgun innate response? Well, that's only possible if the innate response has an immunological memory that's specific. And we were always taught that it didn't have a specific memory. So is it heresy to even ask this question? As it turns out, the innate immune response, the monocytes, can indeed retain a memory, an immunologic scar it's called, from prior microbial exposure. And recent reports indicate that this innate immune memory is mediated through epigenetic mechanisms. So the bacteria is recognized by the monocyte, and then it goes through epigenetic reprogramming, and then it's a changed monocyte. It's a trained monocyte that responds more robustly to stimulation by the same agent, producing more cytokines. So here's an example where you have, let's say, cytokine response measured here, and here might be the initial exposure to the antigen, and then here is a second exposure to the antigen, or a microbe for that matter, and you have what's called a trained immune response, a much more robust production of cytokines in response to the infection, because the early monocyte response does indeed retain a memory. So we have known that the later immune response, the adaptive immune response, has a memory. That's the whole basis of so many assays that currently exist. So, for example, for tuberculosis, there are interferon gamma release assays that use 2 or 3 specific TB antigens that don't cross-react with BCG, and these antigens stimulate interferon gamma release. And then the amount of interferon release is measured after it's been stimulated, and based on the magnitude of that release, you can determine whether this is, or the number of cells that are producing interferon gamma, you can determine whether that blood has recently seen tuberculosis. And there are two highly sensitive and highly specific assays that now exist, recently reviewed in JAMA 2014. Now, is it possible to develop such an assay for early Lyme disease based not on the later stage adaptive immunity, but based on these new findings from the innate immune response? Well, we have the IL-1 beta assay for Lyme that was recently developed in Europe, and that's thought to be a surrogate marker of active infection. And it's designed to measure the early pro-inflammatory response of cells after stimulation to Borrelia. So a prospective study was conducted in Cluj, Romania, and reported at a conference last year. 58 adults with M.D. diagnosed erythema migrans and 23 adults with tick bite who had no erythema migrans. And what did they find after the IL-1 beta was measured? What they found was that there was a 64% true positive rate using the IL-1 beta assay among patients with erythema migrans versus 48% true positive using the IgM Western blot. So clearly a meaningful improvement in the sensitivity of the assay in early Lyme disease. So that's helpful, particularly when you have funky-looking rashes and you're not sure whether it's a Lyme rash or not, or someone comes in with flu-like symptoms, let's say, and you're not sure if it's flu or not, and it's very early Lyme disease. You could actually do this assay, and it's more likely to be detect the positive than the IgM Western blot, at least in this particular study that was suggested. It had a similar false positive rate, so the sensitivity looks good. It was about 86 to 87%, 86% specific in this particular study. And interestingly, the IL-1 beta positivity declined after treatment. It went from 64% early in Lyme disease down to 3 months later, 19%. But the IgG Western blot was positive, and 75% were positive on the IgG Western blot 3 months later. So this suggests that this might be a marker of active infection that becomes negative shortly after the infection has been treated. So that's actually quite interesting and potentially exciting as well and useful clinically. So that test is being further developed and validated. Okay, now how do physicians measure clinical outcomes? A lot of it is just subjective report. Patient comes in complaining of being tired or having pain. Physician writes down pain, fatigue, doesn't use any scales at all. It's really just, is it bad? How bad is it? It's all very subjective. And if you try to communicate from one physician to the next, there's really no common metric that we use. So it's kind of like a Tower of Babel that these physicians are using in trying to describe to one another what's going on with the patient, which is problematic since what's going on with the patient is very important.
This should stay fine.
It can't always be measured with a blood test. So the M.P.H has developed what's called the Patient-Reported Outcomes Measurement Information System, called PROMIS. This is free of charge. It's standardized to the U.S. general population. It has a T-score for each domain that is studied. The mean is 50 and the standard deviation is 10. It's free of cost, and it's well correlated with legacy measures. So the best way to think about it is that it's a thermometer for subjective outcomes. It actually gives you a score on various subjective outcomes, such as general cognition, global mental health, global physical health, sleep disturbance, anxiety, and depression. So here's a profile for one patient, for example, and what you see is general cognition had a score of 30, so that's 2 standard deviations below 50. That's because 10 is 1 standard deviation. So this person clearly has impaired general cognition and impaired global mental health as well, 1.5 standard deviations below the U.S. population norm mean of 50. So a variety of mechanisms across diseases can lead to similar domains or patient-reported outcomes, such as pain or problems with social functioning and being able to socialize, or problems with sleep, or problems with fatigue. And fatigue is of great interest in Lyme disease since so many of our Lyme patients experience fatigue. But fatigue is not unique to Lyme disease. It's seen in a number of other diseases, and even therapies can induce fatigue. fibromyalgia, rheumatoid arthritis, chronic fatigue, systemic lupus. All of these can be associated with fatigue, and what we need is the common metric, and that indeed is what the PROMIS system offers, a common standardized way to measure the same clinical outcome and to be able to then compare what's the severity within one disease versus another disease. A very useful effort by the NIH. Okay, so in conclusion, there are two synergistic developments that may improve patient care. Recent findings regarding immunologic memory of the innate immune system offer the potential for a better assay. We need to know, is it sensitive in the early as well as the late stages? We need to know, is it sensitive with other genus species of Borrelia burgdorferi? We need to know, does it become negative after treatment, indeed, as it appeared to in the CLUES study, and how long does it take for it to go down to zero after treatment? And if it starts climbing again, does that mean that an infection has reactivated? We want to know what the specificity of the assay is, especially among individuals who have other infections, such as mono. We know that the IgM Western blot is more likely to have false positives, for example, with mono. It would be nice to see if this assay is much better, which it might be. And finally, recent advances in biometrics allow for improved patient-reported outcome measures that may enable a common clinical language across clinicians and across diseases for assessing patient severity as well as progress. So there's a lot to be enthusiastic about, and that's what I hope to have conveyed to you today. I thank you for your attention. I thank my collaborators and co-investigators. In particular, I want to highlight the people who worked on the lab comparison study. Samantha Cofino, who's a pediatric neurologist now at Columbia, a resident. Carl Brenner, who played a very important role in helping in the writing of this particular manuscript. Martina Pavlikova, who's a statistician who conducted the data analysis. And colleagues at Oxford Immunotech who are working on the IL-1 beta assay, Wolfgang Pekin and Louis O'Day. And thank you once again for your attention.
Everyone, at this point, too, we have a few more segments, but I just want to remind everybody at this point that you see the screen up. This is the website for the legislative website, and then also you can send any questions that you may have. If you're not able to contact a presenter directly, please forward those questions to DC Tick-Borne at dutchessny.gov, and we will get you a direct response. Next up, we're going to be hearing from newly elected Senator Sue Serino. Sue is also taking a bite out of Lyme, if you want to say. She is heading up a Lyme or a tick-borne disease group through the state Senate under her guidance to work on this at the state level. So she's provided us with a small YouTube video to address our attendees.
Good morning. I'm New York State Senator Sue Serino, chair of the Senate's Task Force on Lyme and Tick-Borne Diseases. As some of you may know, I hail from Hyde Park in the Hudson Valley, and our area in particular has been especially affected by Lyme. As the mother of a son who has suffered the debilitating symptoms of the disease, I have a personal connection to this issue, and I have experienced the barriers to diagnosis and treatment firsthand. The frustration and the anxiety that comes with this struggle is very real, and it's time to stop the scourge of Lyme in the Hudson Valley and across our state. I am honored to be leading the Senate's task force this year, and my main goal as chair is to bring Lyme to the mainstream. Last year, under the leadership of Senator Kemp Hannon, the task force really brought the issue to the forefront, and I intend to utilize that momentum to its fullest. Since coming to Albany, I have attended statewide conferences on the issue, met with constituents and activists both in Albany and in the district, and have been researching a handful of legislative measures extensively to ensure that we're doing all we can to tackle this disease from every angle. This year, we were able to secure an unprecedented $600,000 in the budget to tackle Lyme, and next week I'll be meeting with the members of the task force in Albany to start talking about how best to maximize these funds, and we'll be holding public forums across the state once the legislative session slows down. I appreciate that this conference is being held over the web because I believe that technology has a critical role to play in stopping Lyme in its tracks. It's all about information sharing and educating our communities. If you're on Facebook, head on over to my page to see my Lyme Disease Resource Center, a one-stop shop full of local resources and tips. This week, thousands of brochures on how to prevent Lyme are being sent to schools and libraries across my Senate district. It's all about getting that information out directly into the hands of the people it affects the most. You have a critical role to play in this initiative of spreading the word. I thank you for taking the time today to get involved in this meeting and for making this issue a real priority. Know that I am fighting tirelessly every day to move the task force forward, to spread the word about Lyme, and to deliver real results.
That was Sue Serino, our senator here from the Hudson Valley. Next, we're going to be hearing from Chairman of the Dutchess County Legislature, Robert Rolison. Our Tick Task Force actually is a legislative appointed committee. So I think it's important for us to hear from the chairman, because without the chairman setting the rules for our DC task force, it wouldn't be here, and we wouldn't have the flexibility to go out and do things like we've done today to be able to spread the word a little bit more, to follow up with what Senator Serino said. So without ado, here is Chairman of the Dutchess County Legislature, Robert Rolison, with the message that's been pre-recorded for us.
Hi friends, Rob Rolison here, Chairman of your Dutchess County Legislature and a supporter of the Tick Task Force. I'm honored to speak to you today at our first ever education webinar. This event will allow us to reach more residents than ever before as we continue to spread the message. Now, May is National Lyme Disease Awareness Month, and another reminder that Dutchess County residents reported the highest number of confirmed Lyme disease between 2007 and 2011, and of any county in the state, and the 9th highest in the U.S. But we're taking proactive steps to keep our residents safe. Today, we've heard from some of the top experts in the field on how to reduce and eventually eliminate this public health crisis. We've also heard from Legislator Donna Bollner, chairperson of the Tick Task Force, on steps your county representatives continue to take to raise awareness and encourage effective preparation among those most at risk. Now, get the facts today. Visit our county one-stop resource at www.dutchessny.gov/be-tick-free to learn more. Now, thank you for your time. Thank you for your dedication. And thanks for helping your partners in the Dutchess County Legislature take a bite out of Lyme.
Again, that was Chairman of the County Legislature, Rob Rolison. Again, this is a group effort. In order to beat any type of tick-borne disease here in Dutchess County and nationwide, I think you've heard from our presenters this morning, it's going to take a multi-layered approach. It has to come from a lot of different directions. There's not one specific answer to this, and I think that partnerships are very important. And a partnership with our county executive and being able to use, obviously, the technology that we've used today in order to have this first ever webinar is crucial. I think we've really stepped up. We've done something that I don't think very many counties, if there any across the nation, have done to really collect information, put it in a format that is accessible to, attendees today, but not even today. It's going to be archived and uploaded to our link off of the Dutchess County Legislature website, and then it will be available to anyone across the nation or anyone who has web access. So again, a partnership with not only our county residents, but also through our county health department and through county OCIS has really helped us to make this event possible today. And I want to thank again all those that helped with this little idea that I got after last year. I thought, what am I going to do to top our panel discussion last year? And I think we've had a successful day in doing that today. And I look forward to 2016 and what we can do. And with that, I'm going to leave us with our county executive, Marcus Molinaro, and he will end our webinar for today. And thank you again for attending.
Thank you for participating in today's webinar. Lyme disease and tick-borne illness is of particular concern and interest to Dutchess County, and we've been proactive. I'd like to extend my thanks to Legislator Donna Bollner for her leadership, along with Dutchess County's Tick Task Force and all those who came together to make this important conversation a reality. Dutchess County continues through a very proactive approach to educate and inform and bring together thought leaders to address Lyme disease, tick-borne illness, and all of the consequences associated. Today's conversation is of particular importance to all of us, and I thank you for being a part of it, as Dutchess County aims to be among the healthiest counties in the state of New York. We continue our efforts to prevent Lyme disease and tick-borne illness, but also to ensure that there's a level of understanding, appreciation, and outreach, and we continue this important conversation.